do not want to go against the big guns.
How are you?
Good, you?
Haven't seen you in a while.
Not withholding transplants from a Okay, these guys don't keep on chatting unless we get started. Good morning. Today is Tuesday, February 7, 2023. The Insurance Committee of the Tennessee House of Representatives of the 113th General Assembly is now in session. Mr. Clerk, please call the roll.
Representatives Capley, Sapicki, Davis, Freeman, Haynes, Hemmer, Hicks, Johnson of Montgomery, Johnson of Knox, Lafferty, Mitchell, Ritchie, Rudd, Rudder, Sparks, Terry, Thompson, Vice Chairman Martin, Chairman Kumar.
Here.
Mr. Chairman, you have a quorum.
Thank you. Members and audience, we are now fully staffed. We have legal power on the panel with us in the committee. I'm going to let our two attorneys introduce themselves since this is the first time that they're attending.
Hello, everyone. Matt Mundy from Legal Services. I'm from Cleveland, Tennessee originally. I've been a legislative attorney for 12, going on 13 years. Half of that time here in Tennessee, half in Nevada. I have 5 children. I usually do state and local. I've been doing that for 6 years here in Tennessee, but I'm excited to be doing something a little different this year, doing some insurance as well. Thank you.
Yep.
Hello, my name's Caroline Miller, and I'm from Nashville, Tennessee, and I have been with the Office of Legal Services for 2 days. So I'm learning, and I'm excited to be here. Thank you.
Wonderful. Thank you. Members, do we have personal orders? Seeing none, I do have an announcement for the benefit of the members. There is an organization called NCOIL that stands for National Conference of Insurance Legislators. And Tennessee is a dues-paying member of that organization. So 2 of our members are entitled to come and attend the conferences that they have. They have 4 meetings a year. I will send you the brochure and other information. They have also offered to come and do a presentation locally, basically explaining what NCOIL does and how you can be a part of it. And I think if you're going to be involved in insurance legislation, they bring significant resources as well as information. I have attended one of their meetings and it was worthwhile. So I will pass that information to you by email when they send the brochures, and we have to make a decision if we want to invite them to come and give us a seminar on their organization. Any other business? Seeing none, our program today is a presentation by the Department of Commerce and Insurance. It is about regulation and the rules for pharmacy benefit managers, PBMs, and how they are being developed and enforced. We will go out of session and welcome the Department of Commerce and Insurance. Thank you for coming to visit us again. Kindly introduce yourself.
Thank you, Chairman. Thank you, Committee. Assistant Commissioner Bill Huddleston from the Department of Commerce and Insurance. I have my Director of Insurance, Scott McAnally, with me. Thank you for having us back this week. I made a joke coming in to Scott that I'm going to try this week to remember to use the PowerPoint, so I'll do my best there. Anyhow, we are here to talk about pharmacy benefit managers, more commonly called PBMs. As Chairman said, the point of this presentation is to kind of go over a primer of PBMs and to give an update on the status of implementation by the department of last year's PBM rules. I guess to start off with this next slide, it probably looks familiar from, I think, a presentation last year that was given on this. But it looks very complex, and to maybe simplify what's up there. Those green arrows indicate flow of money, and the orange arrows indicate flow of services. What's on the slide is PBM is in the middle, and then parties that they're directly related to are the other blocks that are up there. But as you can see from the slide, the health plan actually pays the pharmacy benefit manager to administer a provided drug benefit. And traditionally, employers providing health benefits to employees depend on health plans to administer the benefits. The health plans typically outsource or use third parties to administer certain functions, and PBMs are just a special type of TPA that is utilized to administer a drug benefit for a health plan. The PBMs also contract with drug manufacturers to negotiate formularies, and they also, in doing this, negotiate rebates from the manufacturer. They also contract with pharmacies so that prescriptions can be dispensed. They pay for drugs, and that's through reimbursement or dispensing fee. Ideally, PBMs negotiate pricing to provide patients and employers better access to medication. They also attempt to ensure that pharmacies can offer competitive pricing to patients and keep prices within a fixed, stable range. And go a little bit more into the functions of what PBMs do in just a little bit more detail. One of the things I mentioned is they develop and manage formularies. Formulary just refers to a set of drugs that's covered by a health plan, and this can include both branded and generic drugs. Formularies are devised by PBMs themselves, and PBMs seek the help of physicians and pharmacists to ensure that the most effective and affordable drugs are on that list. PBMs also establish pharmacy networks. They also, as I said before, negotiate rebates from the manufacturer. Those rebates, depending on the agreement with the plan sponsor, are dispersed back to the sponsor. It just depends on the agreement that they have. And then also, the big thing probably that PBMs do is claims management. So, approve or deny a claim, pay the claim, settle the claim. And I guess that would lead me to the next slide. I think it's a good place to move to it. Claims management is really what PBM started with a long time ago. And over the past few years, as the demand on the plans for drug benefit increased, the role for the PBMs increased as well. So that's kind of where those other functions got introduced as functions for the pharmacy benefit manager. And up until last year, the PBMs really, with the Department of Commerce and Insurance, were just part of a registration program. There was really not a lot of regulation around it. It was more of a licensure program. Legislation that passed last year brought a couple public chapters into effect. Public Chapter 998 and 1070 both went into effect January 1st of this year. And they both greatly expanded the department's regulatory authority around PBMs. 998 requires routine audits of PBMs, and 1070 addresses reimbursement, dispensing fees, and financial inducement to persuade a member to use a certain pharmacy. I'm going to move on now to what the status of the department is right now with implementing these new laws. We did work on emergency rules, got those developed last half of last year and in place to be in effect January 1st of this year. And we have worked on permanent rules and still actually working on those to be in effect July 1 of this year. We had a rules hearing last week and it was really pretty well attended at the department. Many stakeholders were there. We got a lot of feedback, and it was really good to hear what all the stakeholders had to say. We are taking comments still from that public meeting through the end of this week to consider as we further develop those permanent rules. Another thing we've done is we've at the department, we did not have a pharmacist or a lot of knowledge around pharmacy. So as you can imagine, that perspective is really important when we're talking about rules that impact the industry. We hired a director of PBM compliance. He's actually here with us in the audience today, Judd Jones. Judd's right here in the front row. But he's a great addition to the department. His experience and education make him a subject matter expert that we can rely on. We also have a RFP out right now that's getting close to closure for external appeals process related to denied PBM appeals. It looks like the timeline for those external appeals, we will have a contract hopefully signed in March, and so external appeals can begin in April. So that kind of, I think, concludes the status for the department implementation at this point. And I would open it up to questions if there are any.
Well, thank you for that brief introduction. Members, do we have questions? While you're thinking, Chairman Lafferty?
Sorry, Chairman, couldn't let it slide by. Just, I've been listening now for 4 years up here about PBMs. Could you reduce it to a third grade level? I know we've got some new members here. I know we've got, and still some confusion amongst myself, even having been here for 5 years, 5 years now. Could you reduce that like you're talking to a third grader and just give your perspective of where PBMs fit into the process of patient, doctor, prescription, production? Real quick, the easiest, most simple summary you can give about how they function and what they do.
Mr. Huddleston?
Glad to give it a shot, Representative. With the PBM, there's no direct relationship to the member of the health plan. PBM works just specifically for the health plan, whether it's self-insured or fully insured. They also do work directly with the manufacturers that make the drugs and work directly with pharmacies. Does that kind of, and Scott may have something to add to that.
Thank you, Chairman. Scott McEnany, Department of Commerce and Insurance. Sorry, I can get my mic to work there. There is some relationship depending on the structure. So you might have a pharmacy benefits manager card if you're a patient. So some health plans still have it all wrapped in. Some health plans have it carved out. When it's carved out, it's probably best thought of as an insurance company strictly for prescription drugs.
Thank you for that.
Chairman Lafferty?
Thank you, Mr. Chairman. I'll leave my questions there. Thanks.
Okay. Chairman Sparks?
Thank you. You know, PBMs are, it's a very confusing topic, no doubt. My stepfather was state investigator up here for the Board of Pharmacy for many years. Always heard him talk about drugs a lot. Are we still losing a lot of our independent pharmacies in our rural areas due to PBMs that many would argue is kind of a monopoly, oligopoly, if you will, controlling drug prices, stifling competitiveness? Are you still seeing that? I know there's been some reforms and a lot of discussion the past couple of years on PBMs.
Thank you, Representative. So Department of Health licenses pharmacies. We did check on that data when we were working on our rulemaking process in December. And last time I checked with the board, it were around 1,800 pharmacies in the state still. I don't know the breakdown between independents and chains. Of course, some independents might have multiple locations. You wouldn't really think of that as a big box chain, but they may have that data broken down to that level. I don't know.
Yes.
But another total number is still about 1,800.
Chairman Spot.
I don't represent a rural area. I mean, I know that many up here do. I was looking at a report where 41 million Americans, I guess, have what they call I guess it'd be a pharmacy deserts where there aren't a lot of rural pharmacies out there. Let me ask you, when you do an RFP, how do you have the competitive nature on an RFP if you're just using the large, there's 3 major PBMs, correct?
Mhm.
But how do you have that competitive nature to bring costs down? Because I'm assuming one PBM wins the contract, is that right?
Yeah, typically, it's possible some employers may use multiple PBMs. I don't see a lot of that, although I do see some employers that use PBMs that aren't one of the big 3. So there is market share out there that's not explicitly just those. top
Have
ones.
y'all, or I may pose this to the chairman and the committee members, have y'all looked at GoodRx and some of their prices, and then even Mark Cuban's new company, Cost Plus RX? Have y'all looked at that?
Just in articles that come across the news, but not in an official study or anything like that on it.
Yeah. I bring that to the committee and the chairman. We've been researching this reference-based pricing. Tasker just took the report up. My healthcare guy reached out to Mark Cuban here recently. We're hoping that Mark Cuban can come up and testify if the chairman and this committee would be willing to hear from him. But they're based in Dallas. But what my healthcare guy was telling me, he said he had surgery on his arm, and there was one prescription drug he had to take. It was $290 through his insurance. Through GoodRx, it was $75, and through Mark Cuban's Cost Plus program, it would have been $4.50. I mean, that's truly a disruptor there. I know the speaker, we've had reforms, and I want to applaud Speaker Cameron Sexton for being so concerned with this issue. He represents a rural area. Like I say, I don't feel that pain that many of his constituents and your constituents may face. I just think it's something that we could look at. I think there's many reports out there. If you just Google Mark Cuban's GoodRx, I think, he owns the Dallas Mavericks. I believe he had said he would have saved the basketball team. I think it was $150,000 on just that company, that business model right there. It's a confusing topic. I think healthcare is purposely confusing. It's the least transparent commodity or service that's out there in the general public. I can't imagine anything else. So I just want to encourage this committee to really look at this issue to bring those costs down. My wife has a cousin that they said they couldn't get access to a drug, and the young child passed away. It's hard for me to believe that exists in our society, but I think there's another lawmaker, Susan Lynn, can verify because it's her constituent. But I just want to encourage this committee and the chairman to really scrutinize PBMs and implement more free market competition. It's a confusing topic, but it's something that this committee and the legislature needs to look at. Thank you.
Thank you, Mr. Chairman. The department per se does not interact with retail sales and pharmacies. They regulate the pharmacy benefit managers because we ask them to. And going back to Chairman Lafferty's question, it's confusing, it's difficult, even when we try to reduce it to the 3rd grade level, and we're talking about a 3rd grader who can read at the grade level, right? I think the way I see it is that the health plan collects money from members for whom they're going to provide healthcare benefits, right? A major part of the healthcare benefits is drugs that those members are going to need to treat their illness. And because the healthcare plan may not have the talent and ability to manage drugs and pharmacies that are very complicated, so they subcontract. They hire a pharmacy benefit manager or drug manager. That manager, they say, okay, 1/3 of our premiums that we receive are probably 1/3 or slightly more are going to go towards drugs. We give you this money, you manage that part for us, and they will do the rest. So the pharmacy benefit manager receives the money, and then now the drugs have to be purchased. They go to the drug manufacturers and go ahead and purchase the drugs. They go to the drug manufacturer and say, you have this blood pressure medicine. I can put it in formulary with this health plan. And since we will be such a big buyer, what type of rebate or discount will you give us? So they negotiate a better price based on their number of members who are going to be using it, the customers that they're bringing. So they negotiate with them, and they also push them to get some rebates. And that becomes a touchy issue that has been that those rebates, how much of those get passed to the health plan, lowering the cost to the members for their premiums, or how much do they keep? And those things have not been transparent because the pharmacy benefit manager cannot really reveal what deal they've gotten with a particular drug manufacturer because that's their a trade secret, so to speak. They can't reveal that. So again, pharmacy benefit manager has received money from the health plan. They use that money to buy the drugs and get discounts. And some of those discounts are meant to be passed back to the health plan. The other thing they do is that when members of a health plan go to a pharmacy, fill their prescription, they will pay a copay. The rest of the money is going to come from the health plan, for which function the health plan has hired the pharmacy benefit manager. So they pay the pharmacies. And there is a battle between battle is too strong a word, but there's a little push and pull between the pharmacies and the pharmacy benefit managers, where the pharmacies feel you're not paying me enough for it, or when pharmacies purchase drugs from a distributor, sometimes they were being compensated at a rate much lower. And to allow them not to be at such a disadvantage, we did pass legislation that gives them a dispensing fee so that if some of the medications, generic medications, were so inexpensive and they were not getting proper compensation from the pharmacy benefit managers. And so those are the main functions that the pharmacy benefit managers do: receive money from the health plan, purchase drugs, get discounts, and then, of course, go ahead and pay the pharmacies as well as including the dispensing fees. Does that help, those three things that the pharmacy benefit managers do? Mr. Chairman?
Thank you, Chairman. Yes, that's a good, that does open my eyes a little bit more to the process. One of the curveballs, though, that I've heard from some of my pharmacists from smaller pharmacies is that there's a clawback sometimes where the PBM then goes back to the pharmacist and says, hey, you owe us money back for whatever reason. Could you elaborate on that, or could the department help with that a little bit more, how that process?
Let us give the department a shot. We've invited them. We don't want to leave them out of our discussion.
Thank you, Chairman.
Mr. Huddleston?
Thank you, Chairman. There is in the practice, and I'm going to try to, I'll do what you said and try to keep it at the third grade level. There is, PBMs do audit pharmacies for past business, and if certain requirements don't comply with the contract that the PBM has with that pharmacy, then they can claw back payments.
Well, thank you. My question for the department is we passed legislation last year, and then we came back and with another cleanup bill. If you were to lump them together, what were the problems that we were addressing? and what solutions did we come up with? First, tell us the 1, 2, or 3 problems that we were trying to address, and then give us what solution did we come up with.
Okay, I think the first problem that the legislation was trying to address had to do with the payments or reimbursement to pharmacists, inadequate reimbursement or dispensing fees were too low. So a revenue issue, essentially. And we have written rules, and I'll let Scott maybe talk a little bit about the rules if necessary, but we've laid out in rules that are consistent with the statute what we will expect in terms of reimbursement and those dispensing fees.
Okay, I think I'm on this time. Yes, Sam. Okay, thank you, Chairman. Yes, that probably was one of the chief complaints was reimbursement. So what we tackled first is with our emergency rules. We've set up the appeals processes to support the statute for a pharmacy to appeal reimbursement that's below their actual costs. And the rules do also address dispensing fees. We heard a lot of complaints about networks. I think the public chapters from last year expanded pharmacy access to networks. And then, of course, it's commonly referred to as steering, can be described in a number of ways, but an incentive to move a patient away from their pharmacy of choice to another pharmacy. So the statute addressed that as well.
Thank you. My other question is that there was a hearing that you held. Thank you. There was a hearing that you held with industry, and you mentioned that they made remarks there and so on. We were not there, so kindly tell us, for the benefit of the members, what were the main points that pharmacy made to you? Not pharmacy, I mean industry.
So I think one of the big things that I took away from it is we did have, like I said, both sides represented there, pharmacist and the PBM side. And because we had worked with both sides kind of to hear what they had to say, I think they did give us some thank yous for the work we'd done on this, on the rules. As you could imagine, the main points from both sides, because they're on different sides of the issue, were different. And we did hear, maybe from both sides, one of the things that they both agreed on had to do with, for the dispensing fee, there has to be a certification, and both sides agreed that there needed to be a place where that could be centralized. That would be helpful. We've talked internally about that, so that's an ongoing discussion. I guess other points off the top of my head, we heard from the PBM side effects on the consumers that would likely result from this. That was to sum up everything they said. I think that was one of the big things.
From the pharmacy point of view, there was something called steering they were complaining about.
Sure. On that, I think the absence in the rules thus far, we've addressed the reimbursement and external appeals, a lot of the financial piece. On the rules do not have anything in them right now about steering. I think we believe that the statute's adequate at this point, but that's still, as I said, we're developing those rules, still an ongoing discussion as well.
Can you define steering or just clarify what that is?
My layman's answer would be that everybody in this room probably has a different idea of what steering is.
Let's clarify it.
Okay. So I think, I'll tell you what, I'm going to defer to Scott on this. I could I could try, but I think he may have a little bit more clear definition.
My understanding of that was that the pharmacy benefit manager may say to the plan member that if you purchase drugs from this particular mail house, it'll be much cheaper to you. So the local hometown pharmacy felt these patients were being steered to mail house pharmacies away from them, and they were losing customers. So that these patients are being steered to that direction. But go ahead and let's look at your slide.
Chairman, we don't have a slide on it. I think Bill was just going to say that, the language in the statute to address that practice in 2022 changed from the 2021 bill. I personally, before our PBM section started, have been taking the complaints from pharmacies since January 1st of 2023. So I've fielded, I think, about 140 so far. Some complaints could have multiple claims, but it's a fairly even breakdown between steering and dispensing fee. So as we're getting complaints about steering practices, we're trying to look at those individually and see if the statute adequately addresses them. If it doesn't, then I think we still have the opportunity, of course, and the authority to make rules to address that.
Thank you. Representative Thompson, I apologize. You've been waiting a long time.
Thank you, Mr. Chairman. Actually, you and Representative Sparks have talked about a lot of the things I was concerned about. I think from what you were saying that y'all are preparing, y'all are researching the effects of the bill that we passed last year, and you'll presumably have a report about that sometime this year. Is that true, or did I misunderstand you?
I don't know of a particular report we'll have. We will certainly be, when things are up and running, be tracking it for business purposes to know how to make business decisions and policy decisions on that.
Well, anything you have would be interesting to me personally, and hopefully, I think the rest of this committee as well. I might mention that pharmacy deserts are not exclusive to rural areas too. So a lot of inner cities have the same problem that are similar to food deserts as well. So there's something that would definitely affect my district, and I'm anxious to hear some of the effects of this law and some information you may have as well. This might be a naive question, but why do you negotiate rebates versus simply discounts in the front end? It would seem like that administratively it would work a lot simpler and a lot more efficiently.
Go ahead.
No, that's a good question, Representative. And my best answer, I've not worked for a PBM or an insurer, but my best answer is, a discount would be something you, like you said, you get on the front end. But I think some of the rebates may result from things that happen during the course of business over a time period. So that rebate may vary based on volume, for instance, that's, sold.
Yes, Representative Thompson.
Okay. In other words, sort of a reward for certain practices by the business. Is that what you're indicating?
I don't know how to call it reward. It's agreed to in the contract.
Okay.
So it's just whatever that agreement is between the PBM and the manufacturer, which, of course, those contracts we don't have privy to at the department.
Okay. Well, thank you.
Representative Freeman, you're recognized.
Thank you, Chairman. And my question is on steering and then on the formularies. You said that you look into claims. How many claims have you reviewed, and what were the findings? What are the potential penalties if someone is found guilty? I have one more question after that.
I'm glad to talk about the penalty piece, that part of the question. And Scott's been working more closely with the complaints that come in. So I'm going to let him take that first part if it's okay. And then I'm glad to go back to the penalties.
I've got 139 through February 3rd, so I didn't include whatever's come in, earlier this week. In terms of resolved ones, the easiest to resolve are when it's a complaint for a Medicare or Medicaid case that's outside of our jurisdictions. There's been a handful of those. We have gotten a good amount of responses in from PBMs. But in terms of resolutions, we don't have many other than we've had one on a dispensing fee attestation letter went out from our department last week to a PBM. So
Yeah, and I think it's important to note, as I said, these rules went into effect January 1st. So it is kind of a process. Things don't happen immediately, but we are working those complaints. Judd Jones, like I said back here, he's working those now. The penalties, so they will be the structure will be similar in some ways to what the department handles with other enforcement. So it's a range, and that can be anything from a warning letter, up to revocation. The things in between could be penalties, fines. It could be an action required of the PBM. For instance, one of the complaints we're working right now is an external appeal, or one that would go to external appeal when we get the contractor. But we're working a couple of those, and at this point, the conversation between the parties, it looks like maybe the PBM didn't provide quite enough information in their first appeal. So they just, part of it is, part of the enforcement would be the proper information. So getting the proper information, but there will be fines, and that's where it may be a little bit different than what we do with other. That may be something that's not similar to other penalty or other programs that we have, because it has to be something that's meaningful. It has to be something that's different than what we would do to an agent, for instance. There may be some difference there. That's still being worked out as we look at statute and what authority we have on dollar amounts and such. But I hope that answers.
Representative Freeman?
Yes, it did. And my second question is, what is your involvement on the formulary side? Do you just give authority? Do you guys have any insight into what that looks like?
We don't have any input into that.
Okay.
And I don't know when these audits start, if there will be any kind of look into that. I mean, there's several other things in that public chapter that we have to do in those audits. So what things in an audit, one thing can lead to another, but at this point, no input.
General Assembly did pass a bill last year, Representative, on step therapy that requires us to address that and look at some rules. So those would be forthcoming, and that's related to formulary. But I mean, otherwise, Bill's right. They don't file them with us or anything of that nature.
Representative Freeman?
Thank you.
Speaker Johnson, you recognize, sir.
Thank you, Mr. Chairman. Could you walk us through the appeals process? When someone makes an appeal, who do they appear before? Is it a board or a body, and how is that body appointed?
So under the statute from last year, the first appellant authority is the PBM itself. So the pharmacy gets the reimbursement, finds it inadequate, forms a PBM, it's below their actual cost. The PBM denies that appeal, then they have right to an external review by statute. That's going to be the vendor that we're quickly acquiring. I think Bill said in March. So there'll be and then the external reviewer's word is going to be final on that.
So they would appear before the vendor. Is that correct?
Yeah, I don't think there's going to be an appearance. I think it's going to be mostly paperwork based. But yes, the pharmacy would.
So they would not actually appear before.
I don't believe we
Anyone?
contemplated any kind of hearing or anything like that. I mean, I think
And
it's
the vendor would make the decision.
yes.
Okay, thank you.
Chairman Sparks, you're recognized again.
Thank you, Chairman. On the rebates, going back to what Representative Thompson mentioned, where do the rebates go? Does it go back to the pharmacist itself, the pharmacy, or does it go back to the consumer?
There's any number of arrangements, Representative, for rebates, and I think industry would be best, and not just the PBM, but the manufacturers that provide the rebates as well.
Yeah.
Probably best suited to answer why they do it and how they do it, but could be a pass-through all the way back to the sponsor. PBM could keep some, wholesalers involved. There's a lot of players in the supply chain.
So basically, PBMs control 85% of the drug market, correct? Three
The general
Three
stat, yeah.
PBMs,
Mhm.
yes. When you mentioned RFP, when you're putting out the RFP, you're talking about the state healthcare plan, just the state healthcare plan.
So on that, the RFP that I was referring to was the RFP just for a contractor to handle external appeals for the denied
Oh, okay.
PBM appeals. Didn't have the staff inside the department to do that, so it's out on contract.
Okay. Well, Chairman, committee, you see it's an extremely confusing topic. With all due respect to the presenters, would it be possible that we could maybe have the Independent Pharmacy Association, somebody speak maybe the next few weeks about this subject? I think it would help. And no telling how much money we would save if we had more transparency, more free market conditions, which all of us would like. I mean, driving costs down. You know, I listened to the governor last night, with all due respect, and we're going to spend a lot of money in the future, a whole lot of money. I get a little nervous about that because we've been on an uptick for past few years. We're going to be on a downtick next couple of years, and really alarms me. I think this is an area that we could really save some money if we dug down. So, Chairman, if there's a possibility we could have some independent pharmacies speak, maybe some rural pharmacists from maybe Lafferty's area, some other areas, I think would help. Thank you for answering those questions.
Thank you, Chairman Sparks. Certainly, drug costs are an ongoing challenge, and we keep on. How many times have we had proposals and bills that are going to lower the cost of drugs, which keeps on steadily rising? That's the reality of it. Members, the other thing is that we do have a representative from the PBM industry available. It may be worthwhile listening to them in the sense that we may have made some statements that are not completely true. Are we misreading something, or something they might have found alarming? So let them come forward. Thank you for being available. We talked about this possibility yesterday. It seems we do need clarifications from you. So kindly introduce yourself and tell us.
Thank you, Mr. Chairman, for the opportunity. My name is Trey Moore. I represent the Pharmaceutical Care Management Association, which is a national trade association for pharmacy benefit managers. I don't have any prepared remarks. I'm happy to answer any questions or provide some clarity. Just taking a couple notes, I'll sort of run through a couple of issues that have been raised, and y'all feel free to hop in with any follow-up questions. I think big picture to Chairman Lafferty's sort of question and trying to track all those arrows and entities in the pharmaceutical supply chain, it's easy to get confused about the flow of the money versus the flow of the goods. But if we just kind of take a step back and think about drugs as any other sort of consumer good or commodity, at the end of the day, you have those entities that are involved on the supply side, those that manufacture, those that distribute, those that sell to the consumer at retail. All of those I would put in the sort of supplier side of the ledger. And then on the other side, you have purchasers, you have consumers, right? I mean, if you're talking about tires, you have those that make and manufacture and distribute to retailers, and you have retailers who sell the drug or sell the tire to a consumer. And that's kind of the end of it, right? You understand the flow there. I think what makes healthcare unique in pharmaceuticals in particular is that oftentimes, and as we've seen, those drugs are too expensive for a consumer to purchase on their own. And employers, 30 years ago decided that it would be good to offer that service to help them purchase pharmaceuticals as a benefit, right? So that's how you get sort of pharmacy benefit. And that's how you got a pharmacy benefit manager. As the chairman astutely pointed out, employers who wanted to offer this benefit, didn't want to do that in-house, right? It quickly grew bigger than they could manage. And so they hire third parties to help them deliver or administer that pharmacy benefit. So I think we would echo, I think that helps kind of cut through all of the maze a little bit. The PBM is simply standing in the shoes of the employer or the health plan behind the consumer, helping them purchase the drugs. Now, as you all know, in healthcare, there's an element that the patient bears on their own through cost sharing, whether that's a copay, a co-insurance where they split the cost, or through deductibles. And depending on the type of plan, that can vary, and depending on the type of drug, that can vary. But that's sort of the 20,000-foot view. So we see ourselves as on the same side of the transaction ledger as the patient, as the consumer. We would welcome overwhelmingly free market solutions to this problem. I think, what we have seen down here offered as solutions, we would beg to differ our free market principles, whether they be through restrictions on how employers or plans can administer, who they can do business with, how much they have to pay. All of that is set by law now. So I think we would take sort of the side of the free market solutions, and happy to work with you all on anything you want to do there.
Well, thank you. Members, do we have any questions for Mr. Moore?
I was just going to say, Representative Sparks mentioned cost plus drugs. I mean, I think it's clear that there is a concern for the well-being of independent pharmacies. I think PBMs share that, right? I mean, there are many markets where you don't have a chain pharmacy, and in order for us to offer a benefit for an employer, we have to have partnerships and providers that are independents. I think what's interesting about the cost plus drugs model, and it's definitely getting a lot of press, but the model currently is a direct to consumer mail order pharmacy, right? So they are bypassing the retailer. And of course they're offering lower prices. They don't have to cover the overhead of that independent pharmacy. They don't have to cover the dispensing fee, which is now $11.98. So off the top, anybody who bypasses the retailer is going to be able to save $12 per prescription. So I think there's a lot to look at in that model, maybe how we can replicate that model in state law and allow employers to buy into something like that, and allow consumers to go shop for the best deal. GoodRx was another thing that Representative Sparks mentioned. I think the interesting thing about GoodRx, it's obviously a sort of a coupon model, but it actually relies on the data and the negotiated prices from various PBMs. So the way it actually works is it's not really a cash pay offer, because at cash pay, they would have to pay the retailer their usual and customary rate. What it is it's the best deal of every PBM out there negotiated into, and for PBMs, it saves them money too, because it's not a claim against, and employers, it's not a claim against the employer. So, the average out-of-pocket cost for a generic drug, and this is a national number, I don't have a Tennessee specific number, but maybe we could get that, is like $5.60, right? So, it's still, we encourage generic purchasing, obviously in those instances where a consumer can get it cheaper we'll encourage, we encourage that. And we support GoodRx, we support Single Care, which is another similar company out there. So as far as market control, I think, to the allegation that there's a sort of these big three PBMs that have too much market share and too much control. I think if you consider the role that PBMs have been asked to play by government through their state employee health plan or the Medicaid program, or through employers in the private sector, or through health plans, it is to go and negotiate the best deal possible on every single drug out there, right? It is to use the PBM's market share to drive down the cost on a per unit basis to save taxpayers, to save employers, money on the benefit, right? It's the balance that employers and state governments have is how do we deliver robust benefits at the most effective cost, right? Because as we know through the shared savings program, right, the more you can save on this side, the more you can spend on this side, whether that's through hiring more employees or whether that's through providing more robust benefits. But back to the issue of sort of the market control or 85%, I think when you take a step back and look at who, or I guess the role that PBMs are asked to fill, it is to negotiate drug prices and administer the claims. But on the drug pricing, typically, especially when it comes to independent pharmacies, we are not sitting across the table negotiating reimbursement with every independent pharmacy out there, right? Typically, an independent pharmacy will join what's called or will contract with a pharmacy services administrative organization, or a PSAO. That is essentially their agent, right? They group together, whether sometimes through a co-op model or through a network of independents, right? And they pool their purchasing power, and then they negotiate with us over the reimbursement. So what do they get paid for the drugs that they dispense? The PSAO market, the big three PSAOs are controlled by the big three wholesalers. So that is the distributor of drugs. The big three wholesalers, Cardinal Health, Amerisource, Bergen, and McKesson, control 90% of the drug distribution market, right? So in order to negotiate effective discounts, you need some scale, right? And I think at least that element of it. So I think that's why I think employers from time to time are attracted to the big three, because it's all about scale. It's just a macro sort of economic issue.
Thank you, Mr. Moore. In interest of time, let me get Representative Mitchell has a question.
Yeah, sure.
You recognize?
Hey, thank you, Mr. Chairman. Yeah, break down the $11.98 cost you were referring to. What caused that?
It was an element of the bill last year called and I don't have the site, but I can get it for you. It's the enhanced dispensing fee. The idea was that in order to protect independent pharmacists, we needed to get them more revenue. The legislature was looking to get them more revenue.
Thank
Yeah.
you.
Members, any other questions? Well, I hope it's been clear. Matters have been clarified, and I want to thank the department and thank you, Mr. Moore, for coming. We will go back into session.
Thank you, Chairman.
Any other business for the committee? Seeing none, do we have a motion to adjourn? Thank you. I know.